make sure that you look at that concavity and assess it according to their anatomy. Look at their whole face. If they're skinny everywhere, well, it probably matches, right? But if they have fullness down here and skinny up here, then you kind of look at that and go, okay, I need to focus on that. So it helps you know where you want to focus.
Patient education is very important, right? You always want to set the right expectations. I always say, we're going to do this, let it settle. We can always come back and add more. Walk your patient through what you know will happen. And, if you've gotten it done yourself, walk them through what you went through. That's the best way of really setting the best patient expectations, is you yourself have gotten it done, right? Informed consent, of course, you want to talk about the potential adverse events, especially being that this is a higher risk area. You just want to approach it properly and tell them, hey, this is a little higher risk area because it is blah, 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 blah. And that is what an informed consent is about. Okay. Now, each person is very unique as far as their anatomy, their aging process. So realize everything needs to be tailored approach. What kind of product you're going to use, what tissue plane you're going to address, and what your goals are, where you see the hollowness. Some are going to be more superior temple, some are going to be more in the mid temple, some maybe in the lateral temple. That's going to be up to you and your creativity, your aesthetic eye to dictate that and explain that to the patient.
And you mentioned the lateral temple. The temple isn't just right here, you guys. It goes all the way back here.
Yes.
So a lot of times we might fill here and they're still empty back here.
Yes.
So assess the entire area, because we can lose volume in that entire area. So don't forget that one. There we go. Anatomy.
We're going to go to anatomy. So these are the bones. These are what you...
And that whole temporal fossa goes back behind the ear area, like back near the ear area.
Yeah. So this is temporal anatomy. So we're going to cross-sect it out and we're going to see what's going on right in here. So these are the layers, 10 layers. Skin, subcu, superficial temporal fascia, as you can see. Then there's the deep temporal fascia, fat pad, the deep temporal fascia. There's a superficial temporal fat pad. Then there's a deep lamina, the deep temporal fascia. Then there's the deep temporal fat pad and the temporalis muscle. And then there's the periosteum and the bone. Okay, so there is, depending on how you do it, it's literally, there's skin, subcutaneous tissue, there's a fascia layer there, then there's a fat pad, then there's the another fascia layer enveloping that fat pad, then there's another layer of fascia enveloping another fat pad with another layer underneath that, and then you finally get to the muscle and the bone. Okay, and the muscle is attached to the bone here, versus in other areas it's not, especially in the movements of the face. This is more of a muscle of mastication. Okay.
So these are some of the layers, kind of this is a cross section of what we just showed you. And just know that on the bone, the temporal muscle is glued. In fact, as I used to inject with needles, and during a cadaver course, I decided to look and dissect that temple away, and I thought I could just lift the temporal muscle off. I didn't know. I thought I could just lift it off of the periosteum, and I had to take a scalpel and scrape it off. It is glued to the bone. So understand that that's where that plane of tissue is, and the deep temporal artery is in that muscle. You're going to find the arteries that are going to be in the muscles that need the oxygen and nourishment. So it's going to be in the SMAS in the muscle. So just know that's deep. It comes back up. You got a facial nerve. Rarely ever I've never seen an issue with the facial nerve when we're doing temporal injections. It lives there. But just know that generally we are going to be right above. We're either going to be in the deep temporal muscle when you inject, or you're going to be in between layer 4 and 5, which is on top of the fascial layer.
All right. So the temporalis muscle.
That's how big it is.
It is a big fan-shaped muscle that fills in the whole temporal fossa. Originates from the bony floor of the temporal fossa and overlying temporal fascia, inserts into the coronoid process of the mandible. So as I said, it's a muscle of mastication. Okay. The fiber orientations are anteriorly oriented, vertically, while posterior. And those are the anterior ones. And then as you get to the posterior, they're more horizontal. Okay. So it's more of a fan shape. It elevates the mandible, retracts the mandible, pulls it posteriorly, helps side-to-side movement of the mandible. And its nerve supply is the deep temporal nerves, and then the blood supply is the deep and middle temporal arteries. Okay.
So this is a great photo of when we were doing our cadaver course of the layers. And you see the muscle down deep, then you see SMAS, you see the sub-Q fat in the skin. This is just we're not even dissecting away 4 or 5 other layers here.
Yes.
But this gives you like a gross viewpoint of the big layers that we're doing. And that SMAS layer is the layer that we really want to know about. We want to know where that is and where that travels to. There's a couple different layers of fat in here too that we didn't dissect away, but it's good to know.
Superficial compartments, not to belabor the point, these are it. Retaining ligaments, there's the retaining ligaments in the temporal area. Superior temporal septum, as you can see, as well as the inferior temporal septum, kind of outline kind of that temporal area in a sense.
And this is why we have an orbital retained ligament that's like right out here. Mm-hmm. And this is where if you overfill the temples, that ligament's going to hold it down, and you're going to have an overfilling that looks weird, like a fullness. So be careful when you know that things are attached to the bone and they're not going to give. When you do temples, make sure you're very conservative with temples and it doesn't overfill behind posterior to that retained ligament, or it looks like it's too puffy.
Puffy.
Yeah.